Good day everyone, I am Alexa Bisitara and for today I am going to report the neurocognitive disorders. So for my topic outline, the neurocognitive domains, delirium, other specified and unspecified delirium, major neurocognitive disorder, mild neurocognitive disorder, major or mild neurocognitive disorder due to Alzheimer's disease, major or mild frontotemporal neurocognitive disorder, major or mild neurocognitive disorder with Lewy bodies, major or mild vascular neurocognitive disorder, the major or mild neurocognitive disorder due to traumatic brain injury, the substance medication-induced major or mild neurocognitive disorder, the major or mild neurocognitive disorder due to HIV infection, major or mild neurocognitive disorder due to prion disease, major or mild neurocognitive disorder due to Parkinson's disease, major or mild neurocognitive disorder due to Huntington's disease, major or mild neurocognitive disorder due to another medical condition, and the major or mild neurocognitive disorder due to multiple etiologies, and lastly, the unspecified neurocognitive disorder. For my intended learning outcomes, at the end of the discussion, students are expected to identify neurocognitive disorders and determine the different subtypes of major and mild neurocognitive disorders. So, neurocognitive disorders. What is neurocognitive disorders? These are the disorders diagnosed on the basis of deficits in cognitive functioning that represent a marked change from the individual's prior level of functioning. Neurocognitive disorders are not psychologically based, they are caused by physical or medical diseases or drugs used withdrawal that affect the functioning of the brain, includes delirium, major neurocognitive disorder, and mild neurocognitive disorder. So as defined ng Diagnostic and Statistical Manual of Mental Disorders 5th edition or yung DSM-5, American Psychiatric Association 2013, neurocognitive disorders are a collection of syndromes in which the prominent clinical features is an acquired decline in cognitive functioning. Importantly, dementia, a term adding to the late 10th century, is widely understood by practitioners and public alike to indicate a common, usually age-related, loss of mental abilities and has been replaced by the term major neurocognitive disorder. So, neurocognitive disorder adversely affect cognition but do not limit independence in daily activities are called mild neurocognitive disorders. So, yung mild neurocognitive disorders daw is affect cognition but hindi nalilimit yung independence sa everyday task na ginagawa ng isang tao. Neurocognitive disorders is a general term that describes decreased mental function due to a medical disease other than psychiatric illness. So, sa mga nagtatanong kung ano ba ang pinagkaiba ng neurocognitive and dementia or iisa lang ba sila, dementia is categorized as a neurocognitive disorder in the Diagnosis and Statistical Manual of Mental Disorders or DSM-5. The term neurocognitive has been applied to those disorders to emphasize that brain disease, disrupted brain function, lead to symptoms of NCD. So, major neurocognitive disorder known previously as dementia. The neurocognitive disorders or NCDs begin with delirium, followed by syndromes of major neurocognitive disorder or NCD, mild neurocognitive disorder, and their etiological subtypes. The major or mild NCD subtypes are NCD due to Alzheimer's disease, vascular neurocognitive disorder, neurocognitive disorder with Lewy bodies, neurocognitive disorder due to Parkinson's disease, frontotemporal neurocognitive disorder, neurocognitive disorder due to traumatic brain injury, neurocognitive disorder due to HIV infection, substance or medication-induced neurocognitive disorder due to neurocognitive disorder due to Huntington's disease, neurocognitive disorder due to Prions disease, neurocognitive disorder due to another medical condition, neurocognitive disorder due to multiple etiologies, and specified neurocognitive disorders. So, the important distinction between neurodevelopmental and neurocognitive disorders, ano yung pinagkakaiba nila, is that neurodevelopmental disorders emerge in the developmental period of life, habang yung neurocognitive disorders naman is which are acquired o nakukuha during the lifespan. Neurocognitive domains. Neurocognitive domains is the criteria for various neurocognitive disorders that are based on defined cognitive domains. The DSM-5 defines 6 key domains of cognitive functioning: the complex attention, executive function, learning and memory, language, perceptual motor, and social cognition. So delirium. Delirium is a clouding state of consciousness in which a person has great difficulty in concentrating, focusing, keeping attention in a straightforward stream of thought. Delirium can often be traced to one or more contributing factors such as severe or chronic medical illness, changes in your metabolic balance such as low sodium, medication, infection, surgery, or alcohol or drug withdrawal. So delirium is the term also derived from the Latin word de, meaning out of, and lyra, meaning to track. The term implies being out of track or deviating from a usual state. The diagnostic criteria of delirium. The disturbance in attention, for example, including reduced ability to direct, focus, sustain, and shift attention accompanied by reduced awareness of the environment. The disturbance develops over a short period of time, which represents a change from baseline attention and awareness, and tends to fluctuate in severity during the course of a day. C. An additional disturbance in cognition. D. The disturbances in criteria A and C are not better explained by other pre-existing established or evolving neurocognitive disorder and do not occur in the context of a severely reduced level of arousal such as coma. And E. There is evidence from the history, physical examination, or laboratory findings that the disturbance is a direct physiological sequence of another medical condition, substance intoxication, or withdrawal. For the epidemiology, occurs often among those hospitalized for another medical issue, up to 24%, and in older individuals. While rate of occurrence is quite rare among the general public, that has 1 to 2%, if it significantly increases to 14% among individuals older than 85 years old. Etiology, CNS disorder, seizure, post-ictal period, migraine, head trauma, brain tumor, subarachnoid hemorrhage, subdural epidural hematoma, abscess, intracerebral hemorrhage, cerebral hemorrhage, and non-hemorrhagic stroke. Metabolic, electrolyte abnormalities, diabetes, hypoglycemia, hyperglycemia, or insulin resistance. For the systemic illness, infection including sepsis, malaria, erysipelas, viral plague, Lyme diseases, syphilis, or abscess. For the signs and symptoms of delirium, the disturbance of attention often manifested by reduced ability to focus, direct, sustain, and shift attention. There is also an existence of repetition of questions. They are easily distracted by irrelevant stimuli. They are the awareness of manifested by reduced orientation to environment and time. There is also a signs and symptoms of delirium usually begins over a few hours or few days. They also fluctuate throughout the day, and there may be periods of no symptoms. Symptoms tend to worsen during the night when it's dark and things look less familiar. There are also reduced awareness of environment, and then their cognitive impairment, for specifically poor thinking skills, is also present. Emotional disturbances and behavioral changes may be visible. Types of delirium. Hyperactive or hyperalert delirium, the hyperactive or hypoalert delirium, and the mixed delirium. So for the hyper or hyperactive delirium, the patient is hyperactive, aggressive, argumentative, and uncooperative, and may appear to be responding to internal stimuli. Frequently, the people suffering come to our attention when awake and quickly falling back asleep. So in hyperactive people here has, from the word hyperactive, increase in movement. There is an impulsive actions, and they have the shorter attention. So hyperactive, they have increased movement, and they show impulsive actions in this type of delirium. As I have read, they are also frequent to people like suffering calm to over attention when awakened, quickly falling back asleep, so they are hyperactive. So hypoactive, they have decreased behavioral or physical ability. The person appears to be a napping on and off throughout the day. And they are unable to sustain attention when awakened, quickly falling back asleep. They also misses their meals, medications, and appointments, and they do not ask for care or attention. And this type is easy to miss because caring for this patient is not problematic and stuff. So for the mixed delirium, this type of delirium includes both hyperactive and hypoactive symptoms. So it is a mixture of hyperactive and hypoactive. The person may quickly switch back and forth from hyperactive to hypoactive. The most common types are hypoactive and mixed, accounting for approximately 80% of delirium cases. Causes of delirium. Delirium occurs when normal sending and receiving of signals in the brain become impaired. This impairment is most likely caused by a combination of factors that make the brain vulnerable, trigger, and malfunction in brain activity. Delirium may have single cause or more than one cause, such as medical condition and medication toxicity. Sometimes no cause can be identified. In a study of delirium in elderly patients, it is identified that there are 5 leading causes of delirium. First is the fluid of electoral disturbance. Second, the infection. Third, the medication toxicity. Fourth, the metabolic rearrangement. And fifth, the sensory and environmental disturbance. For the treatment of delirium, first and foremost, treat the underlying cause. Second, the environmental interventions. The cues for orientation must be used also, for example, calendar, clock, family pictures, or windows. Frequently reorient the patient. So including in the treatment of delirium is we should always reorient the patient. Have family or friends visit frequently, making sure they introduce themselves. Minimize staff switching, and doctors may also prescribe drugs to control agitation. So dito sa mga treatment, dapat palaging ipa-remind sa mga patient, ipa-reorient sa kanila kung sino sila, sino yung mga tao na nasa paligid sila o bumibisita sa kanila. Okay din na gumamit ng mga bagay na makapagpapaalala kung sino at kung ano sila. For example nga, yung calendar, clock, family pictures, and windows. Dito tayo sa other specified delirium. This category applies to presentation in which symptoms characteristics of delirium that cause clinical significant distress or impairment in social or other important areas, but do not meet the full criteria of delirium or any disorders in the neurocognitive disorder diagnostic class. Example nito is subsyndromal delirium, isang delirium-like presentation involving disturbances in attention, higher level thought, and circadian rhythm, kung saan the severity of cognitive impairment falls short of that required for the diagnosis of the delirium. Dito naman tayo sa unspecified delirium. This category applies presentation kung saan yung mga symptoms characteristic ng delirium is nakakos ng clinical significant distress or impairment in social or other important areas of functioning predominate pero hindi namimit yung full criteria para sa delirium or any disorders under sa neurocognitive disorder diagnostic class. So major neurocognitive disorder. The diagnostic criteria for major neurocognitive disorder is A. Evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains based on B. The cognitive deficits interfere with independence in everyday activities. C. The cognitive deficits do not occur exclusively in the contents of a delirium. And D. The cognitive deficits are not better explained by another mental disorder, for example, major depressive disorder and schizophrenia. Specify. Major neurocognitive disorders should be specified without behavioral disturbance and with behavioral disturbance, and specify the disturbance. Specify the current severity if it is mild, moderate, or severe. For the mild, for example, the difficulties with instrumental activities of daily life, for example, yung mga housework and like pagmamanage yung mga pera natin. And for the moderate, difficulties with basic activities of daily living, kagaya ng feeding and dressing, and severe or pagiging fully dependent na. Major neurocognitive disorders also describes the symptoms of a large group of disease causing a progressive decline in individuals' functioning. Yung most common na neurocognitive disorder is Alzheimer's. So for the mild neurocognitive disorder, the diagnostic criteria of neurocognitive disorder includes A, evidence of modest cognitive decline from a previous level of performance in one or more cognitive domains based on B, the cognitive deficits do not interfere with capacity for independence in everyday activities. C, the cognitive deficits do not occur exclusively in the context of a delirium. And D, the cognitive deficits are not better explained by other mental disorders, for example, major depressive disorder and schizophrenia. For the epidemiology, major and mild neurocognitive disorders prevalence rates vary widely depending on the etiological nature of the disorder. Dementia occurs in 1 to 2% of individuals ages of up to 65 and up to 30% of individuals by age of 85. So mild neurocognitive disorders also is characterized by a less extreme cognitive decline in one or more areas such as attention, memory, language, social cognition, and etc. People with these disorders can still live independently but still struggle in some cognitive areas, for example, traumatic brain injury. The differences between mild and major neurocognitive disorder. People with mild neurocognitive disorders have impairments in their conscious brain functions, prominent enough to produce testing results lower than those found in people unaffected by a disorder, but not prominent enough to produce a serious life disruption. Individuals with major vascular neurocognitive disorder produce test results that are considerably lower than those produced by individuals with a mild form of the disorder, have impairments that at least partially eliminate their ability to live successfully without some of outside care. We should also remember that delirium is characterized by notable disturbance in attention. Major neurocognitive disorder naman is characterized by significant decline in both overall cognitive functioning as well as the ability to independently meet the demands of daily living. Sa mild neurocognitive disorder naman is characterized by a modest decline in one of the listed cognitive areas. So tandaan natin na yung major neurocognitive disorder, significant siya na dinidecline yung overall cognitive functioning ng isang tao. While yung sa neurocognitive disorder naman is characterized by a modest decline na including kahit isa lang sa mga listed cognitive areas. Here also, another thing to remember, major neurocognitive disorders experience a substantial decline in function or loss of independence as a result of profound cognitive impairment, while the mild neurocognitive disorder experience only a modest cognitive decline as a result of function relatively impairment. So major cognitive disorder, substantial function, overall result or loss of independence talaga dito sa major neurocognitive disorder, while sa mild cognitive disorder is modest decline nga. So here we have the major or mild neurocognitive disorder due to Alzheimer's disease. The diagnostic criteria of Alzheimer's disease: A, the criteria are met for major or mild neurocognitive disorder. B, there is insidious onset and gradual progression of impairment in one or more cognitive domains. C, the criteria are met for either probable or possible Alzheimer's disease as follows. And D, the disturbance is not better explained by cerebrovascular disease, another neurodegenerative disease, and the effects of a substance or another mental, neurological, or systemic disorder. So Alzheimer's disease is a progression condition in which means the symptoms develop gradually over many years and eventually become more severe. It affects multiple brain function. Alzheimer's disease is also slowly progressive neurocognitive disorder with a preclinical phase in which the individual may be asymptomatic for many years. Alzheimer's disease slowly destroys or sinisira niya yung memory and pag-iisip ng tao, and eventually yung ability ng tao to carry out yung mga simple tasks sa daily life nila. So epidemiology, Alzheimer's disease is the most common diagnosed neurocognitive disorder is observed in nearly 5.5 million Americans, with 7% of those between ages 65 and 74, 53% between 75 and 84, and 40% older than 84. It should also be noted that somewhere between 60 to 90% of dementias are attributable to Alzheimer's disease. So naalala nyo yung sinabi ko kanina na yung most common type ng major neurocognitive disorder is Alzheimer's disease. So the risk factor neurocognitive disorder due to Alzheimer's disease is gender neutral. Occurrence rate is equal both in males and females. Family history and age increases the risk of developing neurocognitive disorder due to Alzheimer's disease. The risk of an individual with a parent or sibling with neurocognitive disorder due to or Alzheimer's disease increases as much as 30% with each afflicted family member. Treatment. Pharmacologic treatment of neurocognitive disorder due to Alzheimer's disease includes two classes of pharmacologic treatment: the cholinesterase inhibitors, or the CIS, and then N-methyl-D aspartic acid receptor antagonists. Although CIS do not stop the disease trajectory, they may slow the decline. So, hindi niya man maitigil yung pagdevelop ng sakit, pwede niya ito mapahina o mapabagal o mapabagal yung pag-progress. So the prevalence, 5 million Americans, several million worldwide, more common in less educated individuals. It is also more educated individuals, more decline more rapidly after onset. This suggests that education simply provides a buffer period of better initial coping. Slightly more common in women, and is also possibly because women lose estrogen as they age, and estrogen may be protective. The range of cognitive deficits, the aphasia, in which difficulty of language, the aprasia, or the impaired motor functioning, the agnosia, in which failure na ma-recognize yung mga bagay-bagay, difficulties with sa planning, pag-organize, sequencing, abstracting information, and cognitive deficits and negative impact on social and occupational functioning. Differential diagnosis, other neurocognitive disorders, other concurrent active neurological or systemic illness, and major depressive disorder. Comorbidity, most individuals with Alzheimer's disease are elderly and have multiple medical conditions that can complicate diagnosis and influence the clinical source. Major or mild neurocognitive disorder due to Alzheimer's disease commonly co-occurs with cerebrovascular disease, which contributes to the clinical picture. So major or mild frontotemporal neurocognitive disorder diagnostic criteria. A. The criteria are met for major or mild neurocognitive disorder. B. The disturbance has insidious onset and gradual progression. C. Either 1. Behavioral variant, and 2. Language variant. D. Relative sparing of learning, memory, and perceptual motor function. E. The disturbance is not better explained by cerebrovascular disease, another neurodegenerative disease, the effects of a substance, or another mental, neurological, or systemic disorder. Frontotemporal neurocognitive disorder is characterized by the deterioration or the thinning or shrinkage of brain tissue in the frontal and temporal lobes of the cerebral cortex. It is also a mental health condition characterized by abnormal shrinkage into parts of the brain called the frontal and temporal lobes. So frontotemporal neurocognitive disorder, the result of damage to neurons in the frontal and temporal lobes of the brain. Frontal and temporal results in frontotemporal. And then frontal lobes kasi is in charge siya sa pag-executive function such as yung pagpaplano, prioritizing, multitasking also, and deciding different social cues. Temporal lobes naman, its major roles in language and emotions, such as understanding words and communication, pag-recognize ng mga objects at mga tao sa palibot, pagiging control sa mga emotions, and paano ito natitrigger. And here's the temporal lobes manage memory storage. However, for people living with frontotemporal disorder, memory changes are not a major symptom for them. For the symptoms, the loss of normal ability to make appropriate decision or control impulsive urges. They also has experience the loss of the ability to show empathy with others or develop personal motivation. Changes in self-grooming or eating habits, language or speaking related difficulties associated with disorder include aphasia. It also includes difficulties with normal body movements such as rigid or trembling muscles, loss of the ability to coordinate the activity of different muscles, unusually weak muscles, and their swallowing problems. And for the treatment, frontotemporal neurocognitive disorder is both incurable and progressive. It gets worse over time, and doctors can potentially manage the effects of frontotemporal dysfunction through the use of medication and types of antidepressants. Prevalence, major or mild frontotemporal neurocognitive disorder is a common cause of early onset neurocognitive in individuals younger than 65 years old. Frontotemporal neurocognitive disorder accounts for about 5% of all cases of dementia in unselected autopsy series. Risk and prognostic factor, genetic and physiological, approximately 40% of individuals with major or mild frontotemporal neurocognitive disorder have a family history of early onset, and approximately 10% show an autosomal dominant inheritance pattern. For the differential diagnosis, other neurocognitive disorder, these behaviors can be severely disrupted even in structured care setting, particularly when the individuals are otherwise healthy, non-frail, and free of other medical comorbidities. For the other neurological conditions, major or mild frontotemporal neurocognitive disorder overlaps with progressive supranuclear palsy, corticosal basal degeneration, and motor neuron disease clinically as well as pathologically. And also, there is also other mental disorders and medical conditions. So here we are in major or mild neurocognitive disorder with Lewy bodies. The diagnostic criteria: A. The criteria are met for major or mild neurocognitive disorder. B. The disorder has an insidious onset and gradual progression. C. The disorder meets a combination of core diagnostic features and suggestive diagnostic features for either probable or possible neurocognitive disorder with Lewy bodies. And D. The disturbance is not better explained by cerebrovascular disease and another neurodegenerative disease, the effects of a substance, or another mental, neurological, or systemic disorder. Lewy bodies are microscopic protein deposits that damage brain over time. Neurocognitive disorder due to Lewy bodies then is ang pinakabagong dementia o the newest dementia na diagnosed with an incidence for 7 per 1,000 individuals among those whose age 65 pataas. Individuals with neurocognitive disorder due to Lewy bodies are often misdiagnosed with neurocognitive disorder due to Parkinson's disease. There are intense neurotransmitter deficits along the dopaminergic and cholinergic pathways. Neurocognitive disorder due to Lewy bodies can be differentiated from neurocognitive disorders, Parkinson's disease, based on chronological onset of symptoms. Individuals with neurocognitive disorder due to Lewy bodies will exhibit cognitive symptoms before the onset of the motor symptoms. Lewy bodies also are abnormal accumulation in cells of a naturally occurring protein called alpha-synuclein, which causes the brain cells to die. Lewy bodies are related degenerative brain disease, causes general brain damage resulting in changes in movement, thinking, and behavior. Spectrum disease is also found in people with Parkinson's disease, which causes problem with movements at an early age. Usually diagnosed after cognitive symptoms have already been developed. And then Lewy bodies share also symptoms with Alzheimer's and vascular dementia, but it also has distinguishing symptoms. Nakakaiba sila sa distinguishing ng symptoms and before onset of chronological onset of symptoms. Symptoms of neurocognitive disorder due to Lewy bodies. For the symptoms, impaired attention, fluctuations in cognition, difficulties walking, short-term memory remains intact. Symptoms naman, changes in motor skills, mayroong tremors, muscle stiffness, loss ng facial expression, problems with balance and postures, and paghihina ng paggalaw and pagsasalita o slowness in movement and speech. Symptoms din sa changes in behavior, mayroong visual hallucinations, delusions, sleep order, anxiety, depression, and apathy. Changes in involuntary functions, there is also bladder and bowel incontinence, falls and blood pressure, fluctuations in temperature regulation, and heart rhythm. So causes, neurocognitive disorder due to Lewy bodies results in a collection of proteins called Lewy bodies that progress through the neuronal synapses. The functional deficits seen are greater than neurocognitive a disorder with Alzheimer's disease as a result of effects on motor and involuntary nervous systems. For the treatment, when developing a plan for individuals with neurocognitive disorder due to Lewy bodies, it is important na ma-modify yung care by having the patient or caregiver rank the cognitive, emotional, and motor difficulties by level of subjective distress. So, importante na ma-rank ng caregiver yung difficulties by subjective distress. The medications are effective with many symptoms including fluctuating cognition, hallucinations, and mood disorders. Differential diagnosis, major and mild neurocognitive disorder due to Parkinson's disease. The distinction between neurocognitive disorder due to Lewy bodies and due to Parkinson's disease is based on the timing and sequence of motor symptoms and cognitive symptoms. So, nagkakaiba sila sa sequence ng motor symptoms and cognitive symptoms. Sa yung tandaan natin, baka malito kayo kung ano yung pinakaiba ng neurocognitive disorder due to Lewy bodies and due to Parkinson's disease. If Parkinson's disease has been diagnosed for at least 1 year prior to the onset of cognitive symptoms, then both expert criteria agree that neurocognitive disorder due to Parkinson's disease would typically be appropriate diagnosis. So for the comorbidity, Lewy body pathology frequently coexists with Alzheimer's disease, transactive response, DNA binding protein 43, TDP43, related pathology, and cerebrovascular disease pathology, particularly the oldest age groups. So, major or mild vascular neurocognitive disorder, the diagnostic criteria. A, the criteria are met for major or mild neurocognitive disorder. B, the clinical features are consistent with the vascular etiology as suggested by either of the following. Number 1, onset of the cognitive deficits is temporally related to one or more cerebrovascular events. 2, evidence for decline is prominent in complex attention, including processing speed and frontal executive function. C, there is evidence of the presence of cerebrovascular disease from history, physical examination, and/or neuroimaging considered sufficient to account for the neurocognitive deficits. In D, the symptoms are not better explained by other brain disease or systemic disorder. Probable vascular neurocognitive disorder is diagnosed if one of the following is present. Otherwise, possible vascular neurocognitive disorder should be diagnosed. Number 1, clinical criteria are supported by neuroimaging evidence of significant paracamal injury attributed to cerebrovascular disease. And 2, the neurocognitive syndrome is temporarily related to one or more documented cerebrovascular events. And 3, both clinical and genetic evidence of cerebrovascular disease is present. Vascular neurocognitive disorder is a condition characterized by disruption in the brain's blood supply that lead to impairment of one or more aspect of conscious brain functions. Vascular neurocognitive disorder then occurs pag yung blood vessels sa brain natin ay nata-damage or nabablock, disrupting the supply of oxygen and nutrients sa brain cells. Can be found in scanning with people with no cognitive symptoms but may lead to changes in function kagaya ng language, attention, reasoning, and memory. Vascular neurocognitive disorder then can occur on its own, but it's more commonly found in person na mayroong Alzheimer's disease or Lewy body disease. And this is known as mixed dementia kasi nga, bakit siya tinawag na, bakit siya known na mixed dementia? Kasi nga present yung Alzheimer's disease or Lewy body disease sa kanyang symptoms and kanyang functions. Sa causes naman, causes ng neurocognitive vascular neurocognitive disorder is stroke, condition that occurs when a brain artery either gets blocked or spring, ongoing health problems that either decrease blood vessel in general health or produce abnormal narrowing in a blood vessel interior diameter. Conditions that can trigger these damaging blood vessels changes include atherosclerosis, hypertension, diabetes, and effects of normal aging process. Treatment ng vascular neurocognitive disorder is incurable and inevitably shortens the lives of affected individuals. Pero, doctors can potentially slow the disorder progression or even stop its effect from growing substantially worse over time. Incurable siya pero pwede siyang mapabagal and mapatigil yung epekto sa paglaki ng substantially worse over time. Treated with the help of certain medications originally developed to treat Alzheimer's disease kagaya ng medications include a group of drugs known as collectively cholinesterase inhibitors and a single drug called memantine. See, for the cognitive disturbances identical to dementia, it is also obvious neurological signs of brain tissue damage, prevalence in 1.5% in people 70 to 75 and 50% for people over 80 years old. Risk is slightly higher sa mga lalaki, caused by blockage or damage to blood vessels. Yun nga sabi ko, cost ng blockage sa damage to blood vessel, and second leading cause of neurocognitive disorder after Alzheimer's. So, vascular neurocognitive disorder is pangalawa sa Alzheimer's. Onset is often sudden, for example, stroke. Patterns of impairment are variable, and most require formal care in later stages. Differential diagnosis, other neurocognitive disorder, other medical conditions, and other mental disorders. Comorbidity, major or mild neurocognitive disorder due to Alzheimer's disease commonly co-occurs with major or mild vascular neurocognitive disorder in which both diagnoses should be made. Major or mild vascular neurocognitive disorder and depression frequently co-occur. Major or mild neurocognitive disorder due to traumatic brain injury. The diagnostic criteria for the A criteria are met for major mild neurocognitive disorder. There is evidence. B, there is evidence of a traumatic brain injury that is an impact to the head or other mechanism of rapid movement or displacement of the brain within the skull with one or more of the following. Number 1, loss of consciousness. Number 2, post-traumatic amnesia. Number 3, disorientation and confusion. And see neurological signs, for example, neuroimaging demonstrating injury, and the neurocognitive disorder presents immediately after the occurrence of the traumatic brain injury or immediately after recovery of consciousness and persists past the acute post-injury period. So specifiers rate the severity of the neurocognitive disorder, not the underlying traumatic brain injury. So here is the example picture. The brain trauma, the primary phase of a traumatic brain injury from direct brain insult, from sharing, compression, and deformation of brain tissue, stretching and tearing of blood vessels, and disruption of VBP. For secondary phase of traumatic brain injury is the hypoxic ischemia, cerebral edema, excitotoxicity, and then oxidative stress. And then the acute response is starts tissue damage, impaired cerebral blood flow, and then disruption, brain edema, and inflammation. And then the myelination, apoptosis, reduced neurogenesis, and then sleep disorders, psychiatric problems, seizures, neurodegenerative disease as a chronic response. So, traumatic brain injury usually results from a violent blow or jolt to the head or body. An object that goes through brain tissue, such as a bullet or shattered piece of skull, also can cause traumatic brain injury. Less dramatic changes in their mental function that can worsen over time. For the epidemiology, nearly 1.7 million traumatic brain injuries happens each year within United States, with 59% of these injuries occurring in males. And then the most common causes of traumatic brain injury are falls, aksidente or automobile accidents, and accidental head strikes o aksidenteng pabangga ng mga ulo natin, for example, sa sahig o kaya sa mga matitigas na bagay. There has also been increase in traumatic brain injury within the military due to recent wars in Iraq and Afghanistan. Accidents are leading cause. Symptoms last for at least 1 week after head injury, including problems with executive function, learning and memory. Memory loss is the most common symptom and may be found in athletes who experience repeated blows to the head, for example, football players. Symptoms: some people affected by neurocognitive disorder due to traumatic brain injury experience symptoms that are severe enough to degrade their ability to lead independent lives. Others experience milder symptoms and retain most of their day-to-day mental function. Neurocognitive disorder due to traumatic brain injury comes in both major and mild forms. Yung mga tao na mayroong neurocognitive disorder due to traumatic brain injury have symptoms that the general public commonly refer to as dementia, including such things as memory problems, a declining ability to think logically, and a declining ability to make decisions or control on one's behavior. People with mild neurocognitive disorder due to traumatic brain injury don't have dementia-like symptoms. Instead, meron silang less dramatic na changes sa kanilang mental function na pwedeng mas maging malala pa habang tumatagal. Differential diagnosis, other mental disorders and medical conditions, and factitious disorder and malingering. Comorbidity, major mild neurocognitive disorder due to traumatic brain injury may be accompanied by other specified or unspecified depressive or anxiety disorders characterized by disturbances of emotional function. Among individuals with substance use disorders, the neurocognitive effects of this substance contribute to or compound the traumatic brain injury associated with cognitive disturbances, particularly among individuals with 2 or more traumatic brain injury. Post-traumatic stress disorder can occur with traumatic brain injury in civilian, military, and veterans populations. So, dapat maging maingat tayo sa paligid natin. Like, hindi natin alam yung mga simpleng bangga sa mga ulo natin, magka-cause siya ng injury. And then, kung mas malakas, maaaring mag-lead ito sa impairment or impairment ng cognitive function natin. Substance medication-induced major mild neurocognitive disorder diagnostic criteria are A. The criteria are met for major or mild neurocognitive disorder. B. The neurocognitive impairments do not occur exclusively during the course of a delirium and persist beyond the usual duration of intoxication and acute withdrawal. C. The involved substance or medication and duration and extent of use are capable of producing the neurocognitive impairment. D. The temporal course of neurocognitive deficits is consistent with the timing of substance or medication use and absence. E. Neurocognitive disorder is not attributable to another medical condition or is not better explained by another mental disorder. So, substance-induced neurocognitive disorder, ito yung mga cognitive deficits that occur as part of a brain disorder. Pero, when they are due to a substance or medication uses, mayroong decline o paglala ng mental abilities that were at higher level of functioning natin. Results from prolonged drug use, especially in combination with poor diet, may be caused by alcohol, alak, sedative, hypnotic, anxiolytic, or inhalant drugs. Brain damage may be permanent and symptoms similar to Alzheimer's. So, similar sa Alzheimer's yung symptoms ng substance medication-induced disorder. Deficits may include memory impairment, aphasia, agnosia, disturbed executive functioning. prevalence. The prevalence of these conditions is not well known. Prevalence figures are more available for the use of these substances and for associated substance use disorders rather than for the neurocognitive conditions. Substance medication-induced major mild neurocognitive disorder are more likely in those who are older, have longer duration of use, and have other risks such as nutritional deficits. The differential diagnosis, individuals na mayroong substance use disorders, substance intoxication, and substance withdrawal are increased risk for other conditions that may independently or through a compounding effect result in neurocognitive disturbance. So comorbidity, substance use disorders, substance intoxication, and substance withdrawal are highly comorbid with mental disorders. In general, the higher the exposure to drugs of abuse, the greater the risk of a substance or medication-induced neurocognitive disorder. Dito na tayo sa major mild neurocognitive disorder due to HIV infection. Diagnostic criteria. A. The criteria are met for major mild neurocognitive disorder. B. There is documented infection with human immunodeficiency virus or HIV. C. The neurocognitive disorder is not better explained by non-HIV conditions, including secondary brain disease such as progressive multifocal leukoencephalopathy or cryptococcal meningitis, and D. The neurocognitive disorder is not attributable to another medical conditions and is not better explained by a mental disorder. So symptoms, the individual should have a confirmed case human immunodeficiency virus or HIV infection. The reason for the neurocognitive disorder is not as a result of other brain conditions such as cryptococcal meningitis or progressive multifocal leukoencephalopathy. The following neurocognitive disturbances are noted: attention, impairment, processing speed, working memory, deficits in executive functioning, expressive language, visuospatial skills, and decline in motor functioning. So HIV infection has affected the brain and occurs about 1 in 5 people kung saan yung mga immune system nila is low enough to let HIV begin to cause damage in the brain. So yun nga, tinatarget ng HIV yung immune system na mahihina, and then after that mas madali matarget ng infection, mas madali matarget ng infection yung brain. For the diagnostic features, HIV disease is caused by infection with human immunodeficiency virus type 1 or HIV-1, which is acquired through exposure to bodily fluids of an infected individual through injection, substance use, unprotected sexual contact, or accidental iatrogenic exposure. The advanced form of HIV infections is termed acquired immunodeficiency syndrome. Advanced form ng HIV yung tinatawag natin na yun na AIDS. Diagnostic of HIV is confirmed by established laboratory methods such as the reverse transcription polymerase chain reaction or RT-PCR assay for HIV RNA and antibody antigen combination test. So kung magpapatest ka ng HIV dapat sa mga laboratory, and they will do RT-PCR test for you. So hindi lang sa COVID yung RT-PCR, ginagamitin siya pang-test sa HIV infection. Some individuals with HIV infection develop a neurocognitive disorder, NCD, which generally shows a subcortical pattern with prominently impaired executive function. Differential diagnosis, in the presence of comorbidities such as other infections like hepatitis and syphilis, substance use disorder, or the methamphetamine use of disorder, prior traumatic brain injury, or neurodevelopmental conditions, major mild neurocognitive disorder due to HIV infection can be diagnosed, provided na mayroong evidence that yung HIV has worsened any neurocognitive disorders because such pre-existing or comorbid conditions. Comorbidity, HIV disease is accompanied by chronic symptoms and CNS inflammation and diseases that can be associated with neurocognitive disorder and NCD. These complications can be part of the pathogenesis of major or mild NCD as well as ANI due to HIV infection. Women and members of underserved ethnic and racialized groups may show variation in the rates of comorbidities associated with neurocognitive disorder due to HIV infection. Major or mild neurocognitive disorder due to prion disease. The diagnostic criteria of this disease are A. The criteria are met for major or mild neurocognitive disorder. B. There is insidious onset and rapid progression of impairment is common. C. There is motor features of prion disease such as myoclonus or ataxia or biomarker evidence. D. The neurocognitive disorder is not attributable to another medical condition and is not better explained by another medical disorder. So prion disease comprises several conditions. A prion is a type of protein that can trigger normal proteins in the brain to fold abnormally. Prion disease can affect both humans and animals and are sometimes spread to humans by infected meat products. The most common form of prion disease that affects humans is Creutzfeldt-Jakob disease or CJD. So in a major mild neurocognitive disorder due to prion disease, disorders of protein in the brain that reproduce and cause damage. There is no known treatment, always fatal, and can only be acquired through cannibalism or accidental transmission. For example, contaminated blood transfusion. An example is Creutzfeldt-Jakob disease, and this CJD disease, it is also main type siya ng prion disease together with myoclonus to dementia and a bovine type and chronotype. The diagnostic features and the classification of major or mild neurocognitive disorder is due to prion disease includes neurocognitive disorder due to a group of subacute spongiform encephalopathies that caused by transmissible agents known as the prions. The differential diagnosis, other major neurocognitive disorders. Major neurocognitive disorder due to prion disease may appear similar in its course to other neurocognitive disorders, but prion disease are typically distinguished by the rapid progression and prominent cerebellar and motor symptoms. So here we have the major and mild neurocognitive disorder due to Parkinson's disease. The diagnostic criteria of these disorders are A. The criteria are met for major and mild neurocognitive disorder. B. The disturbance occurs in the setting of established Parkinson's disease. C. That there is insidious onset and gradual progression of impairment. D. The neurocognitive disorder is not attributable to another medical condition and is not better explained by another mental disorder. So, Parkinson's disease, mas ito ay kinoconsider na pangalawa na mas kilala na disease after sa Alzheimer's disease. And then, Parkinson's disease is a brain disorder na nagakos ng unintended or hindi mai-control na movements such as shaking, stiffness, and difficulty with balance and condition. Degenerative brain disorder, dopamine pathway damage, and 1 out of 1,000 people are affected worldwide. Chief difficulty of these disorders are motor problems, tremors, posture, walking, speech, and not all Parkinson's disease will develop with dementia. 75% survival rate for 10 years and up years of after diagnosis. Diagnostic features. The essential feature of major or mild neurocognitive disorder due to Parkinson's disease is cognitive decline observed at the time of or following the onset of idiopathic Parkinson's disease. The neurocognitive disorder is viewed as probably due to Parkinson's disease when there is no evidence of another disorder that might be responsible for the cognitive decline and when the Parkinson's disease precedes onset of the NCD. Differential diagnosis, major or mild neurocognitive disorder with Lewy bodies, major or mild neurocognitive disorder due to Alzheimer's, due to vascular neurocognitive disorder, due to another medical condition, and then antipsychotic and induced Parkinsonism. So for the comorbidity, Parkinson's disease may coexist with Alzheimer's and cerebrovascular disease, especially in older individuals. The compounding of multiple pathological features may diminish the function abilities of individuals with Parkinson's disease. Motor symptoms and frequent co-occurrence of depression, psychosis, REM sleep behavior disorder, or apathy can make functional impairment worse. The major or mild neurocognitive disorder due to Huntington's disease, the diagnostic criteria are A. The criteria are met for major or mild neurocognitive disorder. B. There is insidious onset and gradual progression. C. There is clinically established Huntington's disease or risk for Huntington's disease based on family history or genetic testing. And D. The neurocognitive disorder is not attributable to another medical condition and is not better explained by another mental disorder. So, Huntington's disease, ito yung condition na kung saan yung part ng mga brain natin is nag-stop ng work properly over time. Ito ay namamana or inherited galing sa parents ng pasyente. It gets gradually worse over time and usually fatal after a period up to 20 years. So, Huntington's disease is a genetic autosomal dominant disorder. It is caused by a gene on chromosomes, manifests initially as involuntary limb movements or chorea, usually later in life. Somewhere between 20 to 80% display neurocognitive disorder, and then dementia follows as a subcortical pattern. The prevalence, neurocognitive deficits are an eventual outcome of Huntington's disease. The worldwide prevalence is estimated to be 2.7 per 100,000, and then the prevalence of this disease in North America, Europe, and Austria is 5.7 per 100,000, with a much lower prevalence of 0.40 per 1,000 in the Asia. Differential diagnosis is the other mental disorder, other neurocognitive disorder, and other movement disorder. The major or mild neurocognitive disorder due to another medical condition, the diagnostic criteria are A. The criteria must be met for major or mild neurocognitive disorder. B. There is evidence from the history, physical examination, or laboratory findings that the neurocognitive disorder is the pathophysiological consequences of another medical condition, for example, multiple sclerosis. And C. Mental disorders like major depressive disorder or another specific neurocognitive disorder such as Alzheimer's disease. Major or mild neurocognitive disorder due to multiple etiologies. The diagnostic criteria are A. The criteria are met for major or mild neurocognitive disorder. B. There is evidence from the history, physical examination, or laboratory finding that the neurocognitive disorder is a pathophysiological consequence of more than one etiological process, excluding substances. C. The cognitive deficits are not better explained by another mental disorder and do not occur exclusively during the course of a delirium. This category is included to cover the clinical presentation of a neurocognitive disorder for which mayroong evidence na yung multiple medical conditions is nag-play ng mahalagang role in developmental of the neurocognitive disorders. In addition to evidence indicative of the presence of multiple medical conditions na mas kilala bilang NCD or neurocognitive disorders, it may be helpful na ma-refer yung diagnostic criteria and text for the various medical etiologies for more information on establishing the etiological connection for that particular medical condition. Unspecified neurocognitive disorder. The unspecified neurocognitive disorder category is used in situations in which the precise etiology cannot be determined with sufficient certainty to make etiological attribution. Coding note: do not use additional codes for any presumed etiological medical conditions, and behavioral disturbances cannot be coded but may be indicated in writing. So these are my references, and that would be all. Thank you for listening, and hope you have learned something from neurocognitive disorders. Thank you.